posterior ribs will appear more magnified than anterior. Spinous processes are more prominent, just like lamps, lighted lamps. Lamps एक જ લાઈનમાં હોવો જોઈએ. બરાબર? એ લાઈન ચેન્જ થાય મતલબ વર્ટિબ્રલ ફ્રેક્ચર છે. વર્ટિબ્રલ ઇન્જરી. લાઈન એકદમ મસ્ત હોવી જોઈએ. Lamps in lines. AP view, anteroposterior view. So heart appears magnified, scapulae overlaps lung. Patient tend to lean backward, clavicle appears higher. Anterior ribs more prominent and spinous processes are less prominent. How we can differentiate P and AP? This is a very good picture. This image itself suggests everything. In chest X-ray, right hemi-opaque lung and radiolution lung. Radiolution and hemi-opaque. They are conditions. This can affect mediastinum. Key mediastinum. So now different types of mediastinum displacement. A. Opaque left hemithorax. Opaque left hemithorax. What it can be? It can be left pneumonectomy or loss of lung volume. Lung નથી તો cavity છે ખાલી. There is cavity. What will happen? Mediastinum will shift. क्योंकि opposite side compensatory hypertrophy થશે. And that is the empty cavity will suck. તો pulled mediastinum થશે. Pulled mediastinum. Okay. Opaque right lung B. Opaque right lung pushing mediastinum to left side. Hemi-opaque and mediastinum shift opposite side. Hemi-opaque lung and mediastinum shift opposite. That means it is pressing and pushing. That means it is fluid. If it is opaque, it is fluid. It is pushing, mediastinum shift opposite side. That means it is fluid. This is cross hydrothorax or glass pleural effusion. Okay. Hemi-opaque lung, but mediastinum is not pushed or not pulled. Then it is consolidation. Then it is pneumonia. Hemi-opaque lung, ARDS, complete washout lung. Parenchymal loss હશે તો pull કરશે, fluid હશે તો push કરશે. બરાબર? સમજાઈ ગયું? Now lucency, radiolucency, black lung, black hemithorax. So it is usually pneumothorax. It is pneumothorax. So it is again pushing the mediastinum on the opposite side. And tension pneumothorax or pneumothorax, it will push mediastinum. Amazing. So not only white opaque lung, not only radiolution lung, just look at the trachea. Trachea क्या है इसे? Mediastinum क्या? Trachea is elevated opposite side. It is mediastinum shifting. हमेशा trachea जो है mediastinum जो है, and it is shifting opposite side is dangerous. We have to do something because shifting as mediastinum causes kinking of IVC, and kinking of IVC causes great hemodynamic changes. Loss of blood volume, acute loss of blood volume to heart, and heart can collapse. Cardiac arrest situation. Heart cannot tolerate, and that is the effect of shifting of mediastinum. The shifting of mediastinum is not good thing. All pneumothorax, unless put otherwise, are tension pneumothorax. Tension pneumothorax ની signs શું છે? Silent chest and prominent extra respiratory muscles, and sternocleidomastoid, working of intercostal muscles. These are the mechanisms of tension pneumothorax. So canal metastasis, and we can see collapsed lung, this line, and radiopaque line, radiolucent line. And so we can see it is collapsed lung with pneumothorax. It is postoperative, the clips and skin staplers are applied post-thoracotomy. Most all thoracotomies are always followed by ICD. So ICD is visualized. Some fact about CT scan. So they are chest X-ray. Chest X-ray usually in our chest X-ray pleural effusion માટે નથી નીકળતા. Surgery માં chest X-ray શું હોય? Usually trauma. And deep fracture હોય અને ICD હોય. So what why we go on ICD? Short case માં ICD નહીં unforgettable આવશે. X-ray માં નહીં હોય તો what procedure માં આવશે. You always review ICD because it's a very important thing, and all graduates must know life-saving procedures. ICU માટે હંમેશા સાધનો મળે જરૂરી નહીં, પણ what is important, air must not be free inside, air must be outside. Negative infrathoracic pressure, re-establishment of negative infrathoracic pressure. એના માટે 12 સ્પેસમાં air ના આવવી જોઈએ, air must be in lungs. So that you must know. Some facts about computed tomography. It is just like X-ray, rotating tube continuously exposing X-rays, and it is the measurement is Hounsfield unit, H unit. Hounsfield units measure high density tissues absorbs more X-ray, so HU negative, more black negative, more white positive. Minus 1000 X-ray plate માં લખેલું હોય HU, you can see. So pathology will be next. Sometimes some tumors are identified only Hounsfield unit. After Hounsfield unit se biopsy is required, especially in renal cell carcinoma. So biopsy is not needed. CT scan is diagnostic. It is a very rare tumor. Very few tumor which can be diagnosed by radiology. Minus 1000 air, minus 70 fat, 0 water, 20 serous food, 70 blood, 1000 bone and calcium. Non-contrast and contrast enhanced. If this is contrast enhanced, early arterial phase, late arterial phase, hepatic or late portal phase, nephrogenic phase, delayed phase. Usually kitla phase by early arterial phase, late arterial phase, portal phase if it is liver, and then delayed. Otherwise early arterial, late arterial, delayed. Third phase by. We inject the dye, there are 3 phases. Significance job. So dye is injected after 15 to 20 seconds. Contrast is in the arteries and organs are not enhanced. Contrast is in arteries. खाली vessel of देखा सर, organs are not enhanced. Late arterial phase. Structure supplied by arteries are enhanced. Now artery माथी dye क्या गई? Structure. Now structures are enhanced. So optimum visceral enhancement is in late arterial phase, 35 to 40 seconds. If it is liver, hepatic or late portal phase, 70 to 80 seconds. The liver parenchyma is enhanced by blood supply from portal vein. If liver parenchyma is enhanced without lesion, then it is portal phase. Nephrogenic phase in kidney, 100 seconds post injection. All renal parenchyma enhanced with medulla. Only in this phase small size renal cell carcinoma can be detected. Delayed phase, wash out. Dye is now washed out from the lesion. We imagine barely 6 to 10 minutes post injection. There is wash out of the contrast from all structure except fibrotic tissue. હવે ખાલી fibrotic tissue માં dye રહેશે. Normal visceral normal organs are washed out. How we can interpret image? You can see here in the image. There is a second arterial phase. There is a portal phase. Lesion in liver. Lesion in liver. So first phase isodense, second phase vessels are opaque vessels. So vascular tumor will be ossified. Then tumor parenchyma will be ossified. Delayed phase, wash out phase. So how we can see tumor? एक ट्यूमर से दरेक प्लेट में अलग-अलग केम देखा से बराबर. See first plate में aorta नहीं देखा था, second plate में aorta देखा, third plate में again aorta is not visible. Delayed arterial phase. In kidney, unenhanced corticomedullary enhancement, nephrogenic. Nephrogenic phase is best to find out small size tumor. Parenchymal lightening, okay? And pyrographic, ureteral margin. So only how we can see in kidney. Okay. So our main surgical head injury and B for blood. Acute blood is right on CT scan. Acute blood. So it is now defined as a hyperdense, isodense. Barabar? Eosinophil echogenicity. Hyperechoic, isoechoic, hyperechoic. Hyper मतलब white, hyper मतलब black. Iso मतलब surrounding structure, grey color. CT scan dense and there is MRI. intensity. Hypointense, isointense. I will define that. Okay, so blood clots first is white in color. Okay, after 1 week it becomes isodense. Hematoma becomes isodense, and after 2 weeks it becomes hypodense, black depression. So chronic hematoma, acute hematoma, and childhood plasma, a black digestion. It happens especially in SDH. SDH मतलब crescent shape, subdural hematoma, between brain and skull bone, brain and skull bone. Sorry, subdural, brain and dura, मतलब it has brain surface. खुलो मैदान से नहीं. So usually it doesn't expand. This is EDH. It is extradural. It is skull bone and dura. So it will be limited by these sutures. Now it is closed. Their suture line will be closed. It is adherent to suture line. Dura is adherent to suture line. Between two suture lines there is a space. So EDH expands transversely. SDH expands tangentially. Any brain surface. Which is more dangerous? EDH. Why? Because it compresses earlier. It compresses brain earlier. SDH is not compressible earlier because it has large space to spread. Okay, the lens and biconvex shape is extendable and crescent shape is a SDH. And yes, you can see here ventricular, so midline shape. Left ventricle is pushed to opposite side. It is a midline shape. Midline shape is dangerous. Epidural hematoma or extradural hematoma. Okay? It is more dangerous than SDH. It is intraparenchymal hemorrhagic confusion, opacity in the brain parenchyma. Intraventricular, intraparenchymal. There is hemorrhaging intraventricular. Depressed fracture. Displaced, depressed fracture. So whole table of skull is displaced. It is more injurious. This is again emergency. If it is completely displaced, we have to elevate the segment. Otherwise, it causes injury to brain. Especially when it is like this rupture dura. Dura rupture the U, it will injure the brain. Again MRI. So what is phenomena? Images generated using powerful magnets and pulsed radio waves passing through the body. Charged protons, T1. Discharged protons acquiring neutral position, T2. Right? So magnetic field is there, magnet active high. Magnetic effect या तो electric stimulus आपको मालूम या radiation आपको मालूम. That causes the proton to charge. The proton elevate है. तो एक इमेज ये आ रहा है. When proton elevates, there is an image. It is T1. अच्छी discharge करते हैं. So proton become neutral. Then नीचे movement है. It is T2. It is opposite movement. तो image पर opposite आवश्यक. T1 में जो white देखता है, T2 में black देखता है. तो this is basically charged protons and discharged protons. ये वाला image ले आना है. It machine computer program चाहता है. Short to inversion time, star image. Fat suppression क्या है? So all fatty tissues are white, which is suppressed. So fatty tissue becomes grey now. Now only white is blood and fluid. Otherwise fat is also white. So fat suppression is useful identifying blood vessels, collection of fluid. That is very difficult when fat is visible. Field strength of magnets 0.3 to 3 Tesla. 1.5 Tesla है 30,000 times the Earth's national magnetic field. आता 1.5 की बात है. How dangerous? ये वहाँ पर implant होगा. Going in the magnetic trajectory, it becomes trajectory. Images are described in intensity, hyper, hyper, and iso. So you understand this phenomenon of angle. Like tables are simplified. T1, T2, T2 plus fat separation, store image. Third वस्तु है Anatomy, pathology. Anatomy in T1 hypointense, T2 hypointense, T2 hypointense. Anatomy बत्ती hypo है. Pathology मतलब inflammation. It is hypo in T1, hyper in T2, and hyper in T2 So tell me, simplified version, T1 is anatomy, T2 is pathology. When you see T1 image, it is anatomy. To identify pathology, you have to look at T2. समझेगी? T2 में problem શું છે? આ બધું white. જે pathology છે, inflammation is white. તો fat પણ white છે. So we have to remove that fat that is stored in T2FS. Now only blood and fluid remains. समझेगी? Inflammation मतलब fluid, connection of fluid. तो બીજું કંઈ સમજવાનું જરૂર છે? Fat T1 hyper, T2 hyper, T2FS નો hyper. Sphincter, mass, wall. Tumor, any wall abnormality, sphincter. T1 is hyper, anatomy છે. Pathology સમજાશે નહીં. T2 hyper, but sphincters lighter, થોડું lighter. Mass is થોડું lighter, more lighter than surrounding normal tissues. And T2FS hyper. Simple formulation સમજાઈ ગયું તમને? T1 anatomy, T2 pathology. T1 જોશો એટલે T2 માં હાઇપો હશે જે માસ લેઝન સ્ફિન્ક્ટર it can be differentiated. T2 માં differentiate થોડું lighter હશે. Definitely we know diagnosis. MRI ખોવાઈ જશે. It is MRI for fistula, perineum fistula. MRI for perineum fistula. So we do usually MRI. It is compulsory before fistula. So that how we can identify. In short, T1 fat suppression at the T2. Okay. So T2 image arrow shows what? Inflammatory tract. There is a tract inside. Arrow passage over. There is a white tract. Fat suppression करो. So hysterectomy fossa fat is gone. Here hysterectomy fossa fat is there. Now this fat is gone. Now this tract becomes more intense. It is fistula tract. So how you can differentiate pathology and anatomy? FVG માં ખરા કે બદલવાનું જોઈએ. એક તો full name. So what is full name? Fluorodeoxyglucose. Positron Anderson Tomaker. Basically it is CT scan. Is it? CT scan with PAT. It is not a good investigation for primary metastatic work. It is good investigation for follow-up. For follow-up after chemotherapy or neoadjuvant therapy. But yes, nowadays PET scan is the established method of investigating metastatic disease. Metastatic workup ma PET scan is now established. Okay. Initially it was not, because false positive result. If there are inflammation in body, it will show us as a malignancy. Hyperactive zone. We have to find out hyperactive zone. Hyperactive zone journal. So that is the site of metastasis. But if it is inflammatory, inflammation again can give you false positive result. But yes, clinically we can judge it. Definitely. I cannot say you everything is good. So this is about